if I start elongating, just let me know. Start giving me the hand signals or something. But again, my name is Rick Kenny. I'm the Director for Respiratory Care. I oversee the Respiratory Care Services, both the adult and the neopeds area, the Pulmonary Function Lab, the Blood Gas Lab, and obviously now our new Pulmonary Rehab program. Our Pulmonary Rehab program began, I just started back in January of last year, and we were just in the very infancy of developing the program, but we hadn't really started seeing patients until about maybe 6 months ago. And so right now we've seen in an average about 10 or 12 patients, and we've had good success with it. So after this program, hope you guys go out and tell everybody you know that we do have this program, and we hope to start increasing the number of patients that we see. So this right now is our Pulmonary Rehab program. So a lot of this, I put the PR in the parentheses so you'll know that a lot of our writings will be with PR as an abbreviation. This is William. He is our face for rehab. He was supposed to be the one doing this conversation today, but he unfortunately was not able to make it, so I've stepped in to dazzle you all with my brilliance. So, and I think you know some of these other therapists, and you know Tara over here, she volunteered and stuff, so, and Brother Joe, he was gracious enough to do this. I saw this and I had to put this in here. So this is a respiratory therapist who actually draws these cartoons. So if you can't see it, it says I've got one. This is Pulmonary Rehab when a team players together. And the part that you have your own ABG machine was quite the kicker for me. So this is a photo of our actual gym here on site. This is shared between pulmonary, cardiac rehab, our physical therapy department, and just a little plug for them that they do offer the employees after hours and before hours use of the gym. So definition of pulmonary rehab. This is according to a 2006 American Thoracic Society, European Respiratory Society statement on pulmonary rehab. Pulmonary rehab is an evidence-based, multidisciplinary, I know we've heard this word several times, and comprehensive intervention for patients with chronic respiratory diseases who are symptomatic and often have decreased daily life activities, integrated into an individualized treatment of the patient. Pulmonary rehab is designed to reduce symptoms, optimize functional status, increase participation, and reduce health care costs through stabilizing or reversing systemic manifestations of the disease. A long word saying that it's a team approach. Everybody work together, get this patient better, and keep them out of the hospital. Education, education, education. You'll hear me talk about that a little bit more. AACVPR is the American Association of Cardiovascular and Pulmonary Rehab. They are the gurus of both cardiac and pulmonary rehab. They set all the standards, all the best practices, and so on. Their statement is pulmonary rehabilitation is an integral component of comprehensive medical therapy for patients with chronic respiratory disease. In general, pulmonary rehab provides the greatest improvement in symptoms, exercise capacity, and health-related quality of the life of any therapy available for a patient with COPD. And then the part down here, in light of this, pulmonary rehab is now prominently placed in virtually all major guidelines for treatment of COPD. So we have the gold standards, and the American Lung Association, you have all these folks are really bringing up the pulmonary rehab as being that. So what are the conditions that are appropriate for pulmonary rehab? We have, you've heard before, COPD, including alpha-1 antitrypsin deficiency. I don't know if you've seen a patient with this antitrypsin deficit. It's nasty. These people die a slow, painful death, and they suffocate along the way. It's very sad to see that. It basically, trypsin is developed to clean up the lungs of infections. Antitrypsin is developed to stop the trypsin from doing its job. Those that don't have this ability, the lung slowly destroys itself over time, and it's really sad to watch. Persistent asthma, bronchiectasis. For those that don't know what bronchiectasis is, that's basically the collapsing of the lung, the structure of the lung. You see where you have the nice, fresh-looking tree of the lung. Over time, the support structure of the lung goes away, and the lung basically collapses on itself. And it's not too comfortable for those folks. Cystic fibrosis. For very young, you'll see that we do treat pediatric patients. Cystic fibrosis, there is a cystic fibrosis clinic at Keck, and they have started talking to us about bringing their patients over for pulmonary rehab. We have not received one yet, but we know that we're getting them soon. Bronchiolitis obliterans, that is basically where the bronchiole itself is destroyed. So everything from the bronchiole where it's destroyed on is no longer functional. So basically that makes the alveoli where the gas exchange is done, and it's no longer functional. Restricted diseases are interstitial diseases, interstitial fibrosis, occupational or environmental lung disease. You've heard us talk about the coal miner's lung, folks that were doing asbestos removal. We have those that are metal shop, and so on. They all have these where metals and those particles get into the lungs, encapsulate that, scar up, and that becomes non-functional tissue. Sarcoidosis, major lung thing for infection, doesn't go away, it infects other organs as well. You have chest wall diseases, kyphoscoliosis. If you've seen severe kyphoscoliosis, you know that it compresses everything down and they curve over and they crush everything. Difficult to take a big breath in. This ankylosing spondylitis, I had to actually look that up. I really didn't know what that was. So what it is that it's the lower part of the spine, over time, due to inflammation, fuses itself, and you lose that mobility of the spine. Where this affects the breathing is that it can also affect the joints of where the ribs meet the spinal column. And it gets in there and it actually freezes those ribs from their expansion, their ability to be able to expand back and forth. And basically the patient can't take in a deep breath because it hurts too much and they're restricted. Neuromuscular diseases, Parkinson's disease. You guys know that, is it Michael J. Fox? By the way, one of the most prominent people with it. It's a neuromuscular, and they lose their ability to control muscles over time, therefore their breathing gets out of control. Post-polio syndrome is a virus that goes against the neuromuscular part. Again, you slowly affect your breathing. This is by far one of the worst ones that I've seen is amyotrophic lateral sclerosis, or ALS, or Lou Gehrig's disease. And I've dealt with patients in home care when I've done this. And these patients, it's a death sentence. There's no ifs, ands, or buts on it. And we try to help them out as much as we can. Diaphragmatic dysfunction, that could be anything from a car accident to a birth abnormality to where I've seen it before when open hearts were prevalent. We'd get, or lung transplants, they would nick the phrenic nerve, which controls the diaphragm, and then you would have that lost that ability to be able to breathe with your primary muscles. Multiple sclerosis, and then again post-tuberculous syndrome. Other conditions, lung cancer, you've heard this before, primary pulmonary hypertension, and then before and after surgeries, before and after lung transplants, before and after the lung volume reduction surgery. For those of you that don't know what that is, it's usually for emphysematous patients with emphysema. They go in and they start chopping away lung to get rid of the bad portions of the lung and allow the good portions to re-expand. And I've actually seen this work very well for patients. Ventilator dependence, and then again, pediatric patients with respiratory diseases, again, it's like cystic fibrosis, very bad asthma and so on. And then, surprisingly, more commonly now is the obesity-related diseases. So when we get a patient, we want to be able to do a full assessment on them and find out what do we need to do for that patient. So again, this is a patient interview. Why are you here? What are you expecting? And going over their whole medical history. The physical exam, diagnostic tests, which are pulmonary function tests, blood gases if needed, and what we call a 6-minute walk, which is where we test the patient for their desaturation levels. Symptomatic assessment is, what are you feeling every day? What are the things that bother you the most? And we'll try to figure out how to help them out with that. And then the muscle, skeletal, and exercise assessment is what are you able to do? What is your body habits? And we're going to work with you on that. Activities of daily living is a very important part because patients with end-stage COPD, they have a very difficult time trying to do anything. If you've ever ran a marathon and you ran a long way and that exertion that you felt, that shortness of breath, that's what a COPD end-stage person feels all the time. And it's not a good way to live. Nutritional assessment, again, is very important. We've been hearing some of the conversations going on. Education assessment, and that is basically what does the patient understand about their own disease? How much information they can go online today, right? And they can read stuff. And if you've ever done that on your own, you can overread. And it can make it seem like, well, this is the end of the world for me. And not literally, but they get that thought in their head. And then that's where the psychosocial assessment comes in. These people start reading these things and they start noticing that they can't do the things that they used to do, and they get very depressed about it. So we want to make sure that they're not suicidal, that their depression is so bad that it's keeping them from doing what they need to do. Yeah. Goal achievement. This is an important part for us because we want the patient to know what's realistic goals. We'll have these patients that will literally, they come in and said, I want to be like I was when I was 17. Well, me too, but then it could happen. So we have to make sure that they understand what it is and what are realistic goals. And then again, an important part is pain assessment. A lot of these patients have been incapacitated for a long period of time. They've lost their physical strength, their muscles ache, their bones ache, and so we want to make sure that if we control their pain and control their symptoms, we can get better participation. This is our consent that we use. It goes over the definition, the components, potential benefits, and it's always potential. It doesn't mean that just because it's stated here, you're going to achieve those. And then the potential risk and discomforts. So, yeah, and it's always, yes?
How many patients do you have now in your program?
Right now, the sad part is we're only seeing one patient right now, but we've seen since the program's begun, I think we're about 10 or 12. And then we've had...
graduated some of them already?
Yes, and we're going to talk about a couple of them.
Okay.
And stuff, so. But and then we talk about the responsibilities of the patient. It's very important that the patient understands that once they come into this program, that they have to do their part. You know, it takes two to dance, and if you only got one partner, you're going to look silly out there. So our plan of care, after the initial evaluation is done, the therapist and the patient come up with the goals and objectives that the patient wants at the end of the program. And then we talk about those during each visit. You know, are we getting there? Then once the initial assessment is done, and we come up with plans for the patient, Dr. Boyd, who is our medical director, has to see that patient before we can actually begin the program. Because we want to make sure that, you know, we're not doing anything that's going to cause harm to that patient. Education, 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 education. Collaborative self-management. Education is an essential component of comprehensive pulmonary rehab. Self-management education promotes learning by doing and taking advantage of teachable moments. And we're going to go into this a little bit more in detail as we go through the presentation. Recommended content should be patient-specific. Every patient's different, right? So you have to have those individualized goals. It is imperative to include early recognition and treatment of exacerbations, including the use of an action plan for all patients. And what this intervention part of it is, during those exacerbations is that we have patients who feel that they can treat themselves at home. They don't want to be admitted back into the hospital, so they're going to self-diagnose, they're going to self-medicate and try to not have to come back into the hospital. We're trying to teach these patients, as soon as those symptoms begin, that's when you want to intervene. You can't treat this at home, you have to get help, so let us help you understand that and give you those abilities to be able to contact the right people at the right time. And then we give educational materials to the patient as well. This is just one of many that are out there. And it shows, I know it's a little hard to see, but you have the chronic bronchitis, and then you have the normal lung, and then you have emphysema in the normal lung. And we teach them the differences and why they feel the way that they do. And then we give them the signs and symptoms that they really need to be paying attention to. And you know, if you check off any of those, that's time to get help. So we do our exercise test, which is a 6-minute walk. And this is we walk the patient, we monitor their heart rate and their oxygen saturations, and we document the distance that they walk. And we do this every visit that they come. And this gives us the, a better way to put it, our graph of progression, so that we know, are we doing you any good or not. And it gives the patient the idea, too, that they're getting better. So the exercise assessment itself is that we check for the strength and endurance, joint range of motion limitations. You'll have some of these people come out, they're little scooters, you know, literally scoot because they walk along. We want to know where the limitations are so that we don't overstress them. Their postural abnormalities, again, kyphoscoliosis. How is the patient with oxygen equipment? And I didn't think too much about this one. In my home care, patients get their 20-foot long cannulas and they're walking along, they know not to trip over that. But we've never ever watched them go from point A to point B with an oxygen tank and stuff. When we educate them, we teach them how to keep it out of the way, but that's about as far as it goes. So we want to evaluate these patients when they're here with their oxygen tank. Are you pushing it? Are you pulling it? How much weight are you carrying? And try to, one of the patients that I saw, not here but in a past life, they had modified a cart to where they could basically put their entire luggage system on it and drag it behind them as they went. And it was like, why are you carrying all of that stuff with you? And once we got her to lighten the load, she found that she could move around and stay out much longer. Didn't put 2 and 2 together. Again, a teachable moment, right? And then subjective endurance and work tolerance. This is really an important one because, again, COPD patients, they get short of breath just thinking about it. And we want to be able to educate them on why you're going through this, and how can we help you with that. Lack of understanding of fitness and exercise. I mean, we're all facing that at one point in time or another. This is where if you don't exercise, you don't get up and you don't move, you're wasting your muscles, and your symptoms are just going to get worse. The ability to pace activities and energy conservation. This is actually a teachable moment here. If you've ever worked with COPD patients in the home or in the hospital, what's the first thing they want to do? They want to get from point A to point B as quickly as they can, because they think that that's going to not make them suffer as much. But we're teaching them that if you take your time, stop, get your air, it may take you a little bit longer, but you're going to feel less exerted, and you're going to feel much better. Like for kind of a comparison for them is that will a car going 100 miles an hour go farther than a car that does 50 miles an hour on the same tank of gas? It's kind of an odd one, but it does work for them. And then the fear of exertion. Again, this is the one where they think that they can hurry up and get to the place that they're done, and that they don't want to get up and they don't want to go from, we have patients that don't go out anymore. They stay at home all the time because they don't want to go through this. With pulmonary rehab, we can actually revert that and actually get them to go. We had one patient who hadn't been to her family's gatherings for 3 years. When she graduated, she called back and she told Will she went for the first time in 3 years, and she had a blast. So the program does work. Balance abnormalities, gait instability, or increased risk of falling. We always have that. Again, it's pushing the thing. They get short of breath, they get lightheaded, and so on. So we always want to make sure that they are able to do their exercise as well. Pain levels and location. If you have pain, you're not going to want to do your exercise program. So we need to make sure that we note the pain, and we have to do something about it. We can't just mark it down and leave it alone. We have to notify the physician that this patient is having pain, and we have to document that. The ability to perform, again, the activities of daily living. We don't think much about it, but vacuuming, they can get pretty short of breath with that. End-stage COPD patients, even trying to comb their hair or doing any of that, they get really short of breath. New studies are coming out. I can't tell you who's doing them right now, but I can tell you that I did learn about this in a national conference that I just got back from, that they're looking at, for you and I to lift our arms up over our head and do whatever we want in a cabinet or cleaning cobwebs or whatever. It doesn't really bother us. But these people who already have restricted lung disease and their diaphragms are flat and their rib cages are already out like this, that little extra bit robs them of that additional space. So it was kind of interesting to see that. So the exercise program, the importance of training program cannot be overemphasized, but before a safe exercise program can be provided, a thorough assessment needs to be done to evaluate exercise tolerance, formulate an appropriate exercise training prescription, detect exercise-induced hypoxemia or bronchospasm, and detect occult cardiac or other non-pulmonary limitations to exercise. The benefits of exercise training are well documented and include decreased dyspnea, increased physical capacity, and improved quality of life. Exercise is an essential component of comprehensive pulmonary rehab program. And again, this is from the AACVPR themselves. So that's like gold. I know this is not that good of a picture, but this is our pulmonary rehabilitation supervised exercise program. This gets filled out every time the patient comes in. And it starts, I don't know, you can't see it, but it does the respiratory rate, the O2 stat, their breaths per minute, breath sounds, and so on. And then these are the different modalities that we use in training. Treadmill, and that's stationary bike. And we got new step, stairs, upper lower extremities exercises, and so on. And that gets filled out on every single patient every single time. And then pulmonary rehab is for any age. I had to do that too. And then that's Will over there. And so COPD age group. Now the color code goes this way. So as you can see, 18 to 24 is usually for the adult group, and the prime from 19, 21 to 15% starts at about age 55 and older. COPD and gender. Now this is the part that kind of gets everybody, is that females more than males. This is true. Well, there isn't anything out there that can prove one way or another why this is. We think that one is that females are a little bit quicker to respond to the medical needs than males are.
So there's probably
More undiagnosed
Right,
COPD
They
males.
seek help.
Yeah.
Okay.
Now the interesting part is that when we saw this, we kind of looked back and it's exactly with our program. I think we've had, what, 2 males and everybody else has been female.
Right.
So
So we diagnose them
You know, again, it's, do they go to the doctor? I mean, my dad's 82 years old, and he says, I'm not going to no doctor. And my dad has COPD. My mom has COPD, and she goes to the doctor. So the psychosocial needs, again, this is an important component for us. A strong trusting bond must be established with the patients in that. And they actually, if you don't like your therapist, you don't like your physical therapist, you don't like your doctor, you're not going to go see them. So it's really important at the very beginning, the very onset of your initial visit, that you make a bond with these people and get them to like you, or like them, and work together. Because if they do that and they like you, and they like the people that they come in and see, they're apt to show up more frequently. And then patients experiencing substantial impairments in psychosocial functioning need to be referred to the mental health provider. Again, this is something that if we note severe depression, suicidal tendencies and all that, we would be neglecting our duties of patient care if we did not report this. Smoking cessation is an important part of pulmonary rehab program. You'll see this in every piece of literature out there about pulmonary rehab. Our program here is that we require the patient is not smoking during this program. That we send them to, we help teach them, their physicians help teach them, get them prescriptions to get them to stop smoking. And so far, I would have to say that if they're smoking, they're doing a really good job of hiding it on us. Because we don't, you can smell it obviously, right? You can see it in just behaviors that being an hour in a room if they're heavy smokers, which most COPDers are, that they can't be in a room that long without having to go out for a cigarette. So we talk about an interdisciplinary approach. For our team, it's our core members are the patient and family, our medical director, which is Dr. Avoid, myself. And the reason why I'm in this core group is because I help to get all the equipment, get all of all these different things that are needed to keep the program running. Without our Tara here, we wouldn't have our photos, and we wouldn't have half of our advertisement. We wouldn't have a lot of stuff. And she's helps to talk with patients when they call in and looking for pulmonary rehab. So she's an important part. And then our core members are honestly our therapists, which is William Rodriguez and Joanne over here. But our team should also include behavioral health, case managers, diabetes educators, dietitians, nurse, pharmacists, and physical and occupational therapy. Yes, ma'am.
I used to work, I still work for cardiac rehab. Do you have a system that a doctor can say, I need a pulmonary rehab also, that you guys can get the consultations inpatient already?
Yes. Yeah, there's actually orders in Cerner.
In Cerner?
For pulmonary consult, or pulmonary rehab consult. We're trying to get the order changed to be pulmonary rehab consult and treat, so that we don't have to call the physician back. The ideal situation would be to take and see the patient while they're here, and to find out, do they qualify for these programs and stuff. So, is it happening now? We have actually folks in our department. It's called a assessor, and they go out and they look through the charts, find patients that qualify for those, and then we'll refer them to our pulmonary rehab team, and then we take it from there.
Another question.
Yes.
Do they have to be Medicare or no? Okay,
No.
because I know for cardiac rehab, Medicare and private insurance are the ones that they take, but they make exceptions for open heart surgeries,
Right.
medical patients. So do you guys do the same thing?
Yeah, right now, as far as I know, we've not had anybody turned down. And we've had private insurance as well, but mostly the Medicare and the Medi-Cal.
Thank you.
So unrestricted lung disease, because they're more severe in their symptoms and comorbidities, we have one-on-one with those folks, and that's per CMS guidelines. So again, we have Brother Joe. I'm sure you're happy with knowing we did this one. And then obstructive lung disease, these folks can be seen in a group setting, and one thing that's really nice about this is, even though we've not had that ability here yet, other facilities that we went out and reviewed, it's very competitive. They sit around and they give each other grief, and they bond the friendship and stuff, so it encourages them to come back as well. And so our workout that we do here right now is obviously a warm-up stretching. You don't want to do any physical activity of any kind without first getting as limber as you can. We work on the biceps and the triceps with or without weights, depending upon the severity of the condition. Lower extremities is by far one of the most important parts, because this is where it moves the body from A to B. And so leg lifts, squats. arm ergometer, which is the hand bike, stationary bike, treadmill, new step, and cool down period afterwards. This is what a patient doesn't want to see. Coming in and seeing all of these people hanging around them while they're doing their pulmonary rehab, that's not a good sign. And then this is another former therapist, used to be here. He's says about this. And then, how do you get your patient admitted into our program? Always prescription from the MD. We need a pulmonary function test prior to them going into the program. That's a requirement. If they've had one done within a year, we'll accept that. We do pulmonary functions right here on site. An insurance card, list of their current medications, and then we have a huge packet of paper which is talking about their exercise capability, their diet, their psychosocial, the whole gambit, and they cannot be smoking. And so this is just a couple of slides on two of the patients. 70-year-old female who was there for persistent asthma, so again, it's just not COPD is the only diagnosis we can see, with hypertension, the status post-CABG was about a year ago. This person had multiple ER visits prior to the program. You open up the chart and it's just page after page of ED visits. After the pulmonary rehab, which she graduated 3 months ago, she's not been to the ED since. And in a 6-minute walk, again, remember we do it every single time, she more than doubled her distance. And I did not write that down, but it was impressive. And then comments were knee-bore tissue. I'm not sure if it was because she was leaving the program, but she really loved going on. Our next patient is a 72-year-old female. Again, notice that it's both been females. And that persistent asthma and chronic bronchitis, admitted 3 times in early 2013. So when she got admitted, within 30 days, she was readmitted. And then within that 30-day window of that one, she got readmitted a second time. So 2 of those 3 admissions, we didn't get anything for because it's under that 30-day readmission. So basically that cost the hospital right around, real cost of about $20,000. So she did the 6-minute walk, and she doubled her distance. No admissions or ED visits since pulmonary rehab, and she's been out, if I remember right, she was one of our first patients. And then the patient commented, and you can read it, she's very happy with it, and she was glad that she joined the program. So how do you get a hold of us? Our extension is 2789. If you're external, you can tell the doctors, the outside number, then extension 2789, our fax number to be able to send prescriptions. And then our hours of operation are currently Monday through Thursday from 7 to 4:30. We're closed Fridays, weekends, and holidays. Right now. When we get busier, we'll relook at our hours. I don't know if you guys, some are old enough, some are not old enough to remember this. This gentleman was the face of Marlboro cigarettes for years. And just 3 months ago, he passed away from COPD. So if they only would have known then what they know now, right? And then this is a list of famous people. I don't know if you can read this or not. But you have like Lonnie Anderson, Leonard Bernstein, Walter Brennan, and so on. So Johnny Carson. And so on, all of these, a lot of famous folks. The one that really got me, I think there's a lot of people who remember, Amy Winehouse. She was diagnosed with emphysema. Yeah. So it doesn't matter what your age is, it'll affect you. Yeah. And then here's the one that I thought was a kick in the butt here. R.J. Reynolds, Sr. and R.J. Reynolds III. These guys are the ones that do the Marlboro and Pall Mall and big tobacco companies. And that's it.
I have a question.
Yes, sir.
How long is the program for the rehab?
It's 12 weeks.
And how often do they meet?
Twice a week. 1 hour each time. And that's our standard. They can actually come back, I think it's a total of 26 times or 32 times. But we leave that additional space if they have a relapse and they need to come back, because they only pay for it once. And then AB and CMS. Yes?
Does your program include the psychosocial aspects within already, within that 1 hour? The support, like dietitian would see them in those days, or is it excluding the 2 days? They still go to the other ancillary?
Yeah, as of right now, the way that we're seeing the program go is that we've not had to include any of these folks in because they've been, you know, super excited, they've been upbeat and all gambit. But what I understand is that 1 hour is for the pulmonary rehab portion itself. Anything outside of that is done separately. So these folks would come in and be part of that. Now, is it billable or anything like that? I have not gotten into that part of it yet. You know, is that just something that we absorb into that, you know, that gets cost to us? Right now, Medicare does not pay very well for this program. It's $37 for 1 hour session. And that's why you heard earlier that a lot of programs closed because of reimbursement. But now that, I've been in respiratory for 30 years. Nowhere in that 30 years did we ever talk about readmissions. Not until this last year. And that now it's everybody's talking about and stuff, so. Hopefully that will increase that cost a little bit and maybe, you know, and do the true interdisciplinary portion of it. But cardiac rehab goes through very similar scenarios, so. And you know, that's another thing is that cardiopulmonary rehab, or cardio rehab and pulmonary rehab cannot be together. It's either one or the other, so. All right, thank you folks.
Excellent. Thank
And
you.
we had 10 minutes to spare.
Thank you so much.